Yeah. Okay, we're finally live for a third session of our live question and answer for Long COVID. I'm Dr. Robert Groysman. Today I have the privilege of being joined by Jennifer Knight. She's not only the administrator of the parosmia group on Facebook that has over 50,000 members, but she's also a nurse practitioner and she deals with this all the time. So we do have our first question, and it is from Mark Cohen. And he is asking, if the SGB doesn't seem to work the first time, what are the chances it would work the second time? So I want you to look at this kind of like a door. You walk up to a door and you know it's a door, you know it opens, you know you're going to be able to get through it. But you try the handle and nothing happens. Do you just give up and say, well, maybe it's not a door? It is a door. It's definitely a door, and it works like a door. So sometimes you need to try it multiple times before it'll open. That's pretty much how stellate ganglion block works. Each time you try it, each time you try to do a stellate ganglion block is the same as you trying to open that door one time. And some people have a very tight door, and it takes a long time to get through it. So yes, the odds are higher each time you do it. It builds on itself. What do you say, Jennifer?
I 100% agree with that. And I think a lot of times, too, the research and discussing it with people like Dr. Groysman that do it, some of it is the mindset, whether you have high anxiety, whether you have your fight or flight is in overload or overdrive, where you are in parosmia, where you are in the recovery. So as with anything, some of it is also a preparing mentally for the procedure.
Right, exactly. So why am I so hung up on stellate ganglion block and the dysautonomia? It's because it works by two different independent mechanisms, and it seems to help with long COVID in two different ways. One is the vagus nerve stimulation, which works on the vagus nerve, has nothing really to do with the sympathetic nervous system. That stimulates the vagus nerve. Now they are connected, kind of on a seesaw pattern, where sympathetic sits on one side and the vagus sits on the other side, or the parasympathetic. And when one goes up, the other has to go down. There's a reflex. It has to happen. So what we don't want is, we don't want 100% parasympathetic or vagus, and we don't want 100% sympathetic. Oh my God, that would be horrible. I mean, you would be coming out of your skin if that would happen. In truth, they're both in the car. Okay, they both sit in the car. One sits in the driver's seat and one sits in the back. So what we want is mostly the parasympathetic or the vagus to sit in the driver's seat, and the sympathetic goes along for the ride, which is great because we sometimes need it. If you almost got into an accident, if you got chased by a rabid dog, if you accidentally disturb a hive of bees or hornets, believe you me that your sympathetic nervous system will be active. It'll jump right in that driver's seat and will get you out of that situation, either to fight or run away. But what we don't want is that sympathetic system sitting in the driver's seat 24/7. And unfortunately, this is what's happening in long COVID. We don't want it there, but it does. And while it sits there, it's changing things in your body. It's making your adrenal glands produce epinephrine. It's changing the blood flow in your brain, and basically it's forcing the blood to go into areas that are needed to run or fight. You'll get blood flow increased to, for instance, your heart and lungs, which increases demand, by the way. So it's not easy to stress your heart by making it pump harder and faster, and it's not easy to dilate your bronchi in your lungs, which is great if you need it for short term, but it creates a lot more work for you. in order to breathe against that. It may seem counterintuitive that it dilates the bronchi, so it should be easier to breathe, but it actually creates more surface area, and therefore it's harder to move air in and out over long term. So, and this changes in the brain too. It makes your eyes dilate because you want to get more light in, um, and it heightens some of your senses while dulling others that are not needed. So I mean, in short, you don't want to be in a sympathetic overdrive or the sympathetic nervous system in the driver's seat 24/7, and that's kind of what happens in long COVID, from the initial insult from the cytokine storm that happens during the initial infection. Do you have anything to add, Jennifer?
No, I think that describes exactly well. And about times after the SGB, after you and other suggest additional therapies, such as a stimulator or even like yoga and breathing techniques, things to keep things in balance.
So yes, you're right, and doing things like yoga and relaxing and basically activating your parasympathetic nervous system is a way to fight this. It may not completely reverse this because the sympathetic still wants to sit in that driver's seat, and it doesn't want to give up that spot. It likes being there, even though we don't need it there. And one of the biggest problems, obviously, aside from the parosmia, the dysgeusia, the anosmia, the ageusia, is this insomnia. Insomnia adds to all this thing and kind of puts it into a positive feedback loop, not in a good way. So one of the issues is that under sympathetic control, your body can't go into deep sleep, or it can't stay there very long, and that is where your parasympathetic shines. That's where it does its work. It heals your body, it maintains your immune system, your inflammatory system, and basically treats and heals most injuries. This happens all in deep sleep. And if you can't get there, and if you don't sleep well at all because you're spending most of your time in light sleep or even being awake, this makes the brain fog worse. This makes the fatigue worse. This makes the anxiety and depression worse. It's horrible. So it looks like Mark, again, is asking another question here. Mark Cohen, and he's asking, are any risks or side effects greater with the second SGB? The majority of the risks or complications that happen from a stellate ganglion block, outside of things that are beyond our control, such as an allergic reaction, which you just don't know. If you happen to have an allergy to a medication, or you develop an allergy to a medication, you don't know it until you get it. Outside of that, it's just skill-based. So no, there's no increased risk to doing a second, third, or fourth. However, if you're doing them in rapid succession, there is trauma to the neck, and it's not going to be very comfortable. Having needles stuck into a similar spot each time over and over again, it's going to be sore, and your muscles are not going to be happy with you. But no, there's really nothing that's going to increase risks or side effects from repeating a stellate ganglion block multiple times, aside just from just soreness. So just getting back to the insomnia again, and what I think is happening is that even if you don't have brain fog, and even if you don't have fatigue from long COVID, you can get that from the insomnia, because you start developing sleep debt. The longer you stay awake or in light sleep, the less your body is able to cope with it. Your brain is tired. Your body is tired. You're very cranky. yeah, you're going to develop anxiety, of course, from that alone, just from the insomnia, you're going to develop anxiety, and that can lead to depression and other mental health issues as well. Um, so I'm not sure if it's mostly from the insomnia or mostly from the long COVID as a primary symptom. What do you think, Jennifer?
Well, I would definitely add to that because as somebody that can testify from having parosmia, and the longer I had it, the more stress I was under, and the more stress I was under, in my opinion, the worse it got. There's a PTSD component to this, to where you anticipate walking into a room and gagging and throwing up, and all the things that come along with parosmia. And so I think it just is a stair step of getting worse and worse and worse and worse. And by the time I had my SGB, I was 16 months into it and had hit a wall, no doubt, hit a wall mentally. And depression had set in. I think that, no doubt in my mind, SGB saved my life, but I had to get to that wall, I think, to the point of getting it. Everything I do in medicine is risk versus benefits, obviously, along with science-based. But, the risk of SGB was tremendously lower than what I was living with at the time. And I am a success story. I had it done last April, and probably got 80 to 90% back immediately, and have continued to improve since then. And probably I'd say 99% today, because I still don't enjoy smelling coffee, and I still don't enjoy smelling chicken, but I can tolerate it. I don't walk in a room and gag. I can go to social events in the grocery store and a restaurant again, and go to work where they're making coffee again, and not make a scene. So risk versus benefits, but also I think that what Dr. Groysman is saying about the insomnia, I certainly had that. That made things worse. Every night I didn't sleep. Every night I, woke up with 2 or 3 hours of sleep and felt terrible. And things got worse and worse and worse over that year.
Sure, and I absolutely agree with you, Jennifer, about the risk versus benefit. I mean, all medicine should be practiced this way. When you're thinking about any treatment, you always have to think about what the risk is and the benefit. And if the benefit outweighs the risk, you do the procedure, and if it doesn't, you don't. Or at least talk to the patient and explain that it's probably not a good idea, but it could be a gray area, I suppose. So with PTSD, I mean, I guess the nice thing about the stellate ganglion block is it also treats PTSD, so you can do kind of a 2-for-1. Although maybe treating the long COVID in the first place would correct the PTSD, but usually once it starts going, it doesn't necessarily go away. Some of the fear components, anxiety and depression that come along with PTSD can still persist, even if everything else goes back to normal. So for PTSD, the mechanism is slightly different because it involves an area of the brain called the amygdala. And that section of the brain sits in the temporal region, which is the kind of the side part of your brain. And you have two, just like everything else in our bodies, we have two of them. And this area of the brain is what stores essentially the traumatic memories or anything that your body really needs you to remember so you don't do it again. So all those things that you need your sympathetic nervous system for the fight or flight, those kind of things are stored in the amygdala. And next time around, your reaction time is much faster. You don't have to think, should I run from an angry dog or beehive or something, or am I going to fight or not? So the problem is that these memories are so traumatic that they continually stimulate the sympathetic tracts in your brain down to the cervical area into the stellate ganglion, and that sets off the system over and over again. So it still uses the same process, just the mechanism is slightly different. And but it still responds fairly well, at least in my hands and a few others. PTSD has about an 80 to 85% response rate to a stellate ganglion block, and the same thing applies as it does to long COVID. Most people are still going to be right side dominant, which means that we always start on the right side with the stellate ganglion block, and a small percentage will be left-sided, or some people are non-dominant and they require both sides because it's not using one side or the other, it's using both equally. And so it's the same thing also with long COVID. So people ask, why do we start with the right side? Well, we start with the right side because the majority, about 80% of people, are right dominant. It has nothing to do with which eye you prefer, which dominant eye you have, which dominant arm or hand, which dominant ear you have, or which dominant leg you have. And believe it or not, you do. You actually have a dominant side for each one. You can use both, but your body prefers one. So the same thing happens in your neck, in your stellate ganglion, and the majority happen to be right dominant. It's just the way we're built. And if you are right dominant and you do the right side, most of the time it takes effect and works. So Jennifer, one thing I get asked all the time is I get local, I get lidocaine put into my teeth, for dental work, and it lasts an hour and a half, and once that wears off, everything comes back, the sensation comes back. So why doesn't the stellate ganglion block basically just stop working when the local anesthetic wears off? And the mechanism is change in blood flow and essentially resetting the relationship between the parasympathetic and sympathetic, which persists way beyond the duration of the block or duration of the anesthetic. So it's the sympathetic system. It's very different from a sensory nerve or even a motor nerve where you're blocking sensations so you don't feel something or unable to move something. Do you have anything to add?
No, I 100% agree with that. It's just a different mechanism. It's than a dental procedure. You guys also use a little steroid. Do you use the steroid as well?
I don't use the steroid, and I'll tell you why I don't use the steroid.
Okay.
Yeah. Steroid is meant for inflammation in the area where you inject it. So if I'm doing an epidural, for instance, and I know that the spinal nerve is inflamed, by placing the steroid within a millimeter or two of the spinal nerve, I know it's going to work and basically numb up the area. And the steroid is going to do its work at decreasing the inflammation. Here, the sympathetic nervous system is not inflamed in the area. The stellate ganglion is not inflamed. The tracts are not inflamed. They're just abnormally firing. It's a functional problem. And they're abnormally firing because they were pushed beyond their limit initially, and it just cannot get back. I don't know if you had one of those toys or a printer where it goes beyond the boundary and it just cannot push back until you pull it back. Do you know what I mean? Like something on a track, and it just moves beyond its normal limit, and it can't pop back by itself. So
that out of curiosity, when it's been done for over 50 years for PTSD vets and others, were they using steroids in it when you do it for that purpose?
I don't use steroids for PTSD when I do my stellate ganglion blocks. I'll tell you why the steroids come in. The steroids come in because this procedure is done by pain doctors. And hang on, a Liberty, I'll be right with you to answer your question. Let me just finish this thought. Okay. The reason that steroids are put in is because we use steroids for everything. You do an epidural, you include a steroid. You do a transfemoral epidural, you include a steroid. You do a facet injection, you include a steroid. You basically include a steroid with everything. It's just the way we were trained. And, in pain medicine, you're treating pain because inflammation causes pain. But people aren't walking around holding their necks, in pain from the stellate ganglion. There's just not an inflamed area. So yes, you can put a steroid in there, but why? The steroid has side effects, and anytime you put something in that doesn't do a benefit, only creates risk, right? So that's sort of the problem. And there's no problem in including it, but it also prolongs the block. Okay, so it makes the local last longer. But other than that, it doesn't really do anything. All right, let me answer A Liberty's question here. What injection chemical do you prefer? So I'm assuming you're talking about a stellate ganglion block. So there's essentially 5 local anesthetics you can use. Each one is different in how long it lasts. Some cause vasodilatation. That means they dilate blood vessels. Others don't. So I prefer to use ropivacaine 0.5%. Why ropivacaine? Well, because bupivacaine tends to be more toxic. And if it gets into a blood vessel, it potentially can cause issues with the heart where you need resuscitation, which is not good. And it can cause a seizure if it gets into your brain. And where we're working, right, in the neck area, there's the vertebral artery, which goes straight to the brain through the through the brainstem, and there's also the carotid artery, which sends branches off into the brain as well. So it's potential problem if you get that medication into an artery, for instance. So others use lidocaine, which is slightly safer, but it's very short acting. And because it also vasodilates the blood vessels, it even lasts shorter than, for instance, putting it someplace where there's not a lot of blood vessels. There's also, like I said, bupivacaine, mepivacaine. There's several different agents, and they all differ in how long the local anesthetic takes to metabolize, and therefore how long the block would last and how long the side effects would last, mainly the Horner syndrome. So I use ropivacaine because my belief is it's not just the initial kind of trying the door, but it's continually trying to open that door for the 4 hours or however long the block lasts. So if we're already sticking a needle into somebody's neck, I wanted to give a little bit extra time for it to control or try to open the door, as opposed to just one try and we're done. See, I'm leaving. I can't open the door, so it must be closed, and I can't open it. A Liberty is also asking if I recommend Valium prior to the procedure. It really isn't necessary. I have done patients as young as 10 years old, awake, without any sedatives. We talk people through it. We make it a very pleasant experience. And it really is not as bad as you think. I know thinking about having needles in your neck, it's scary. I mean, especially if you don't know what's going to happen. I'm thinking about filming basically a video and posting it on basically from start to finish how we do the procedure, and it really is a relatively easy procedure to get through. And the majority of patients say that's it. I was expecting worse. So yes, you can take Valium prior to the procedure, but it's really not necessary. And when you do, you're going to be sedated and you're going to be drunk, which makes it difficult to drive. And, you're going to be kind of out of it. So I would prefer not to have any sedatives. It also makes it much easier to assess after the procedure to see how you feel. And another question is depersonalization from long COVID. So this would be kind of a psychiatric or psychological symptom. And I use the stellate ganglion block mainly for those two things, for neurological symptoms such as smell and taste, the brain fog, the fatigue, the anxiety, the depression, and PTSD. So basically neurologic and psychologic not really sure how well it works for depersonalization per se as a isolated symptom. What are your thoughts on this, Jennifer? I'm sorry, I've been talking a whole lot.
No, that's fine. I too don't know too much about the depersonalization. I know I can speak from me personally, and then some of the research I've done being, an admin on the page, but on the Facebook page. But, for me, I definitely had gone into somewhat of a depression and had the anxiety, which has never been an issue in my whole life. The insomnia, brain fog, I had it all. And the SGV definitely improved all of the above. The PTSD part of things is ongoing because I lived with this for a year and a half in a severe mode where I anticipated being in situations where I knew I was going to not enjoy things and probably a few times make a fool of myself. So that's where the PTSD comes in. I know this was done for PTSD initially, and I do think it helped with that some. I think it helped me recover a little faster from it, but I still, if I have that smell, and that COVID smell is still there for me occasionally with, it's maybe like driving in a car and exhaust fumes, I can still get a whiff of it. And
Right.
that's when PTSD kind of hits me, and I'm like, you're good. It's not going to last. You can do this, and then you move on. So it's better, but I don't know overall with the depersonalization part of things.
Sure. And depersonalization is kind of, I guess, kind of an out-of-body experience, sort of, I guess, is the best way to describe it. And it's kind of hard to tell if you've recovered from it or not. But yes, insomnia is another one that responds really well to the stellate ganglion block. And believe it or not, the whole thing with PTSD really started with Eugene Lipoff, Dr. Lipoff in Chicago, who basically released the first study in 1990. And then it was adopted by Sean Mulvaney, who's in Maryland. And I don't know if you had a chance to see his video on 60 Minutes, because that's what really kind of cemented the stellate ganglion block for PTSD. I remember the very first one I did. It was on a military vet. He was a Marine, and I did it for him. And I went into my office, and back then I had a much smaller office, and the recovery room was right next door to my main office. And I hear crying. I mean, I thought I heard the guy. So I run in there, and I'm trying to figure out what happened, because I'm thinking maybe he's having pain from the SGB injection that I did, and he was crying for joy. He basically said he felt like everything has been lifted off his shoulders, and he felt like he did before he joined the Marines, basically as a recruit. All that anger and the fear and the triggers, everything was gone. And I mean, that was amazing for me to watch the transformation, basically from somebody who came in and the way he looked to right immediately after. And it took me a while to also figure out, it's not just the duration of the block. It actually lasts after, and way longer after. You may never have to repeat it again, at least for PTSD. We have a question from James Blevins. His question is basically psychological with stress, anxiety, PTSD, and gastrocardio issues. Gastrocardio, that's an interesting one. Why can't doctors understand when I go for checkups and tell them my symptoms? Okay, so let's look at it this way, James. I've been practicing medicine. I'm a hypothetical doctor. I've been practicing medicine for the last 10 years. And I know what I know. I know what I know. I get some information from CME and from articles. But when the heart does something, I treat it with this. And that's how I always treated the heart when it's diagnosed the way it is. So it's difficult to kind of think outside the box. And there's no definitive diagnosis for long COVID. It's symptom based. There's no test for it. Correct, Jennifer?
That is absolutely correct. And James, I can certainly relate to what you're going through in your question, because even me being in the medical field, going to see different providers before I had my SGB, and none of them, I can 100% say none of them knew what this was. And long COVID was a word for them. It was almost a dump. Oh, well, they're having insomnia, they're having, this and that. And so they would attach the word long COVID to it, versus what we know now, a couple of years later, with a lot of the other more serious long COVID issues and problems. But I hear you, and I sympathize with you on trying to find somebody to listen. Now, I will tell you, there are people out there, so search and research and find somebody that will listen to you, because any provider that dismisses you, move on 100%. I'm a provider. Move on. I promise you, you'll find somebody that'll listen to you.
Yeah, James, you should never be gaslighted, okay? Your symptoms need to be listened to and taken seriously. You shouldn't be told that you're crazy or you're imagining it or it's in your head, because obviously you're not. But this really reminds me of fibromyalgia. When I was training, that was a brand new diagnosis. We didn't have a test for it. And a lot of docs, a lot of my colleagues, they didn't take it seriously. It's all in your head. It's a ridiculous diagnosis. It doesn't exist. And that really rubbed me the wrong way, because you're basically saying to a patient, hey, all these symptoms that you think you have are not real. And that is so demoralizing to a patient. I mean, they're coming to you as an authority on the subject, and you're essentially dismissing them. And that is not why you should have gone into medicine. I mean, that's just not the way medicine is supposed to work. So, I mean, just to address, I guess, some of the things that you talked about, the anxiety, again, comes from the sympathetic overdrive. It forces your brain to be anxious. The PTSD is, again, a consequence of trying to anticipate the next time you're going to have a symptom. And it's very traumatic. It is. And over time, that does become PTSD. The gastric symptoms, things like digestion, are all controlled by the vagus nerve. So if you're having diarrhea or you're having issues with cramping or abdominal pain, all of this is because the vagus nerve is not doing what it's supposed to be doing. Luckily, this is not a sympathetic issue; it's a parasympathetic issue. But the second thing that could be happening with the gastric system is during the initial COVID infection, it loosens some of the junctions that protect your bloodstream from your gut, what we call the barrier. And some of the microbiology, microbiota, what's the right word I'm thinking of, Jennifer? The microtome, I guess, the biome of the gut can excrete toxins and can actually get into the bloodstream itself, and that can cause a slew of problems from that alone. As far as the cardiac, well, again, it goes back to the sympathetic. Sympathetic drives heart rate and makes it go faster. Sympathetic makes the heartbeat harder, so the ejection fraction is higher because it's forcing the heart to really pump harder. So some people feel palpitations or pain in the chest or discomfort in the chest, and all that's from the sympathetic overdrive. I hope that answers answers your question, James, and thank you. Microbiome, yes, that's the word I was thinking of, and it just escaped me. So I forgot what we were talking about before, James.
Actually, A. Liberty had asked a question, and she may have deleted it.
Yeah, I see.
And I just don't, I think that's a whole different conversation, a whole different subject that maybe needs to be discussed separately, because that is, I don't know if that's a long COVID symptom, if that's something that maybe she had post-COVID, but
What symptom? What symptom did she mention?
I don't think she mentioned it. I don't quite remember what the comment was, but it was, I think it was in reference to saying that SGB could possibly help with depersonalization, because it was the parasympathetic involvement, possibly. That's kind of what I thought I remembered reading. But
I have seen I've seen quite a few people mention in your group, the parosmia Facebook group, and also in the group that I run, the Long COVID treatment group, talking about depersonalization. There's been some talk on it, but it doesn't seem to be mentioned very often. I mean, most people talk about smell and taste because that's what people notice and are upset about mostly. I mean, the parosmia and the and the anosmia and the taste issues also really, really impact people's lives. What I want to say though is this is a really shout out to all the doctors out there. Please take your patients' symptoms seriously. Don't gaslight them. Really listen to them. And they're not making this stuff up. They're not looking for any gain here. They just want you to help. They want to be taken seriously, even if you don't know how to help them. At least reassure them and take them seriously. It's just really not the way medicine is supposed to run. I mean, people come to us for help, and we shouldn't dismiss that. That's all. I mean, it's just common sense stuff, and I really feel, when I took the Hippocratic Oath, saying, first do no harm. I think we're doing harm if you don't really try to help, or you don't take your patients seriously, or they hear you kind of laughing with your nurses when you leave the room. It's very demoralizing and demeaning to them. So, do your best and, try to help people as best as you can. I mean, this is just really common sense stuff. Just in general, with how medicine is these days. And we're going to get obviously new conditions and new problems. And it's not going to be all the stuff that we learned in medical school or residency. So we have to be prepared to deal with anything new that comes out. And we can't dismiss people's concerns. Okay, that's all. Anything else you would like to add, Jen?
And in my neck of the woods, politics does play a big part of it, unfortunately. And politics got mixed up in medicine during COVID, and that's unfortunate. And so, when it may not be apparent immediately when you have a provider that dismisses you. Sometimes that dismissiveness is due to not really believing that COVID is the cause of some of these long COVID or long haulers issues, such as parosmia, or that parosmia is as severe as it can be. I mean, we have people on our page that have had to have NG tubes, hospitalizations, and what goes along with all of that is your mental health. And so you need to find somebody that will holistically deal with both physical and mental health, but is also not politically driven in their care and how they either gaslight you or treat you. Because sometimes I've seen providers throw, Valium or Xanax or, things like that out at people with long COVID, thinking this is just a mental disorder, even SSRIs. And if you don't deal with the whole person, had that been done to me, who knows where I would be right now.
Exactly. And I don't want people to feel like there's nobody listening. And if there is nobody listening, if you don't have any family, if you don't have any friends, I posted this in my group, but there's betterhelp.com. I don't have anything to do with them. I'm not invested with them or anything. I just like them because they're available online. They're basically, give service in every state. and you could talk to a live therapist. So, essentially, somebody can listen. And I just don't want people doing something they're going to regret. And this is a short-term problem. We will get through this, okay? There's going to be a final cure to this. It's just I don't want people making a rash decision based on how they feel right now, and you can't take back. So, if you're having suicide thoughts or you've tried, please, get some help. There's two numbers that are available for every citizen of the United States. I don't have them in front of me, but I believe I posted in the group. You know what I'm talking about. They're similar to 911, but you basically call the number and you could talk to somebody to be taken off the ledge, talked off the ledge. So Liberty is asking a question about her son who had a stellate ganglion block and had a seizure. Okay, so let me first say that out of the 1,500 plus stellate ganglion blocks that I have done, I have never had a seizure once. So seizures happen because a little bit of the local anesthetic, and doesn't matter which one it is, it could be lidocaine, it could be ropivacaine, it could be bupivacaine, it could be mepivacaine, or any of the other ones. If a little bit, about 1 milliliter or 2 milliliters, get into an artery, not a vein, an artery, you will get a seizure because these agents are, can activate the nervous system, and that's how it causes the seizure. So, especially in the neck area, because there's the vertebral artery there and the carotid artery. There's a couple of other arteries like the inferior thyroidal artery. And there's a few unnamed arteries that sometimes show up, which is why I really prefer to do this using ultrasound, because using fluoroscopy or X-ray guidance, you don't see any blood vessels. Yes, you aspirate, like I aspirate on a syringe before injecting to make sure that you're not in a blood vessel. But guess what? Sometimes you're still in the blood vessel and you don't aspirate any blood. That can happen. So it's better to see the vessel if you can. So yes, putting in even as little as 1 milliliter of a local anesthetic into the vertebral artery or the carotid artery will cause a seizure. And you have to basically take all the necessary precautions until the seizure stops, and then you can proceed. But obviously the procedure is over. So if you got into a blood vessel, your son did not have a stellate ganglion block. Also, if your arm goes numb or stops moving, that's called the brachial plexus block. We do this for shoulder surgery. We do this for bicep surgery. It's called basically either a supraclavicular or an interscalene nerve block, and you're basically blocking the nerve roots that come out of the spine, and that's a little further out from where we actually want to put the medication, which is closer to the midline of your neck. So both those things mean that you did not have a stellate ganglion block; you had something else.
And I will add, just in defense of you guys that do this, that's not a long-term. There's no long-term effects from that. It's just a temporary. And then, like you said, I mean, the studies that I looked at prior to my SGB is it's very, very rare. If you get somebody that knows what they're doing, like Dr. Groysman, then, like he said, he's never had one. And so you ultrasound guided. That's why it's very important, because it's live. It's not like an X-ray. But also what I read, and correct me if I'm wrong, is there's no long-term effects from that particular seizure because of the reason of the seizure. Is that correct?
Right. You'll never have a seizure again from this. It's just because the local anesthetic made its way to the brain and it's very activating, and it causes a seizure. Once it stops, you're never going to have it again. If you end up doing a brachial plexus block, like I said, it's something we do intentionally if we want to do surgery on a shoulder or a bicep or something on the arm for a patient, and it lasts the duration of the anesthetic. And once that wears off, it wears off and everything comes back. The sensation comes back, the movement comes back. But my point is that if you have a numb arm, you didn't get a stellate ganglion block, you had a brachial plexus block, which is fine, but it's not what you came for. You didn't come to have a shoulder surgery, I hope. You came to have a stellate ganglion block. And Jennifer posted the number for, I guess, for the Suicide Hotline. And you can dial this any state in the United States, and it's 988. And again, I know it's hard to talk about, and some people feel very alone and isolated. Long COVID makes you isolated, especially if you have parosmia or anosmia. You can't go to your family dinners or holiday dinners, and it's really a shame because it is isolating. Family a lot of times don't understand, and I've seen this posted over and over again. It is really a shame, similar to how doctors sometimes ignore and gaslight you. I've seen this with family members, I've seen this with friends, and it's just, I don't know, it bothers me. And I guess I don't know what else to say about that, Jennifer, but I wish people would care about each other more.
And that's true. And I think that's where the depression and things come in because, in my life, I'm a very extroverted person, and yet I could do nothing. I couldn't go to somebody's house and eat. I couldn't go to church events that had potluck. I couldn't go even to coffee hour, things that I had been doing my whole life. And so it is very isolating. And then you also have on top of that the downplaying, unfortunately, with family members and a lot of friends. I lost friends over it that just kind of went by the wayside because they just could not understand how I couldn't stand going out to eat, or and everything's revolving around food. So that's why this page that Megan actually started, and I was with her in the early days, was for the Facebook page I mentioned, was for the group to know you're not alone, and you've got people out there that get it, that understand it, and that want to help you and be there for you. And that's all the admins of our page and now your page want.
Yeah. So just to kind of summarize, Jennifer is an administrator of the parosmia page on Facebook. It's probably the busiest, most active page when it comes to parosmia from long COVID. Now, just to say that, parosmia can occur from other things, but long COVID is the most common right now. And you know about my group, which is the long COVID treatments and success stories. Not quite as big as Jennifer's group, but we are growing. And I try to put information there regarding only treatments and success stories. So it kind of complements what Jennifer's group does, which is a support group. My group more focuses on looking at different treatments, vetting successful treatments and some fake treatments out there, and celebrating the successes that people have. In fact, we had two people today, a mother and a daughter team that both did very well with the stellate ganglion block. Both recovered from parosmia, so I'm very excited, and they were very excited too. I don't know if they're going to post. They are members of the group, but I don't know if they're going to post. So I'll leave it at that because I don't ask anybody to post, and probably one out of 10 people that I treat that are successful actually posts to either group, to the parosmia group or to the long COVID group, long COVID treatment group. But it's fine. I'm not doing this for likes or publicity. I'm doing this to help people. I mean, that's why we all do what we do, and that's the reason I went into medicine. I mean, why else do it?
Correct. I will back up a little bit because you were talking about videoing and maybe even posting just how it in real life time, how it works. I have a video of mine. I'm happy to share it. My husband did it, and we videoed like even the ultrasound, the screen, so that people could see exactly where the needle was going in. You can see the medicine going in, my reaction. It takes 15 seconds. It was totally painless and 1,000% worth it for me. And while I understand it doesn't work for everybody, it was for me.
No, I'm glad I helped you. Mine take a little bit longer. I take a full 10 minutes, and it's not because I'm slow. It's just because I'm meticulous and careful, and I check and double check and triple check before injecting at each spot to make sure that it isn't in a blood vessel, and we're not putting the medication anywhere it's not supposed to be. I mean, can you do it that fast? Sure, but I'm in no rush. Is my point.
Yeah, my 10 seconds was the actual injecting of the medicine, not the prep.
Okay. That's good.
Yeah, the actual medicine entering my neck part of it.
I understand. Yes. Yeah. So, this is not a half an hour procedure, but it does take about 5 to 10 minutes to complete from start to finish, basically from the time the needle goes in to the time it comes out. And yes, the local anesthetic is put in around 15 to 20 seconds and you're done. I tend to put it in several areas as opposed to just one. So it is a little bit more, I guess, protracted, but, we get good results. And sure, if that's something you want to do, you can send it over my way, or you could just post it in the group if you like. I don't want to scare anybody though with needles and stuff. So I was going to try to make it, I don't know, a little bit edited so that it doesn't, so it's not as scary. But including most of the details, basically, if that makes sense.
I'll send it to you, and you can post it if you want to. But I give you permission. How about that?
Well, I would probably need to get like written permission from you because I don't want to put any, unless you do it yourself. But I don't want to put anything that's HIPAA protected in the group that's that's yours, without some kind of written permission that you're okay with it, even if you tell me it's okay.
Okay. Nope.
Does that make sense?
Yeah, it definitely makes sense.
So I know we started a few minutes late. If there's anything else that we need to discuss, please ask now, or if not, I'd like to thank Jennifer Knight for joining us today and helping us out. And just so you know, all these are completely unscripted. And so that's my cue, I guess, to finish up.
Well, I appreciate you having me on. I hope this helped even one person. Sounds like a couple of people that were joining us may be calling you to set up an appointment, which is awesome. Spread the love, and thank you for doing what you do to help everybody, because it is definitely an understood illness for sure.
It is, and it is true. And a lot of patients that I do take care of are what I call rescue patients, and that what that means is that they've had the stellate ganglion block somewhere else, and either didn't have Horner syndrome or didn't get a good result. I'm not going to tell you that every single one of them does recover with me, but a good percentage of them did see a difference in how the block went down and how they felt after the block compared to their original 1, 2, 5, however many they've had either locally or wherever else they traveled. So, I think we're doing some good work here. All right. Well, thank you so much, Jennifer, for joining us. And I guess we will end the stream.
Awesome. Thank you so much again for having me. Everybody have a wonderful weekend.
Thank you. Bye-bye.